I'm Mike Kelzer. Growing up in my family's pharmacy, life moved fast. There was always something to do, someone to help. But the moments that meant the most to me as I think back were the conversations my dad and I would have about business and life itself. We'd get so absorbed. We'd talk for an hour and it would seem like 15 minutes. This podcast is my way of keeping those memories alive. There's no scripts, no outlines, no fluff, no hidden agendas. It's just real honest talk about the business of pharmacy and sometimes a little more. Let's dive in. Annie, introduce yourself to our listeners.
I am Annie Eisenbeis. I'm the Director of Practice Development at the Missouri Pharmacy Association. I kind of wear multiple hats. One is overseeing our public health grants that involve pharmacists and pharmacy teams in innovative solutions to public health needs or crises. And then my second big hat is as the lead network facilitator for CPESN Missouri.
Annie, I see that you went after pharmacy school about 5-6 years later. You went to get your MBA. What was the impetus for that?
So I practiced as a community pharmacist for 5 years or so after graduating. And then the Missouri Pharmacy Association had an executive fellowship in association management. And so I actually applied and was the first executive fellow with the Missouri Pharmacy Association. And that kind of spearheaded the concept of needing to have almost a more business acumen and then also be able to speak the lingo. Because most of the people that I was communicating with were not necessarily pharmacists or even in healthcare. So I really wanted to be able to better understand finances and then also operations, people management that we all know did not happen in pharmacy school. And then it's kind of a really important role. But it was a learn on the job versus backed up with evidence and best practices.
How much of that was you wanting to get that information versus having those initials behind your name? And trust me, I wouldn't do it if I couldn't get the initials behind my name. So that's not a slam by any means, but how much was it truly to get the information, or was it also because you felt you needed the look of the degree where you were and where you were going to go?
That is a great question. So probably first 5 years of pharmacy, Annie, was probably more about those initials. But after starting the fellowship, and actually also thinking that I may want to own my own pharmacy a couple of years before that, I realized how much value there was in on-the-job training and experience, and how some of the things that I would have learned in school were just really that starting place. So getting my MBA was probably more of a starting place versus giving me the necessary credentials or experience. And with that, actually, the reason I got the MBA where I did was because they offered an executive MBA. So everyone in my program was out for at least 5 years and having practiced in whatever field. So we had people retired military, we had agriculture, we had 2 other pharmacists, actually, both from completely different spaces, docs, engineering, basically any background. There were about 35 of us. And I can say, too, I probably learned more from the other industries and learners in my program, because it was actually, we all met together, even though it was mostly virtual, it was not on your own time. So I did learn a ton from the other folks in industries. So even in thinking about pharmacy knowledge, like especially in those grant programs that we look at and manage, thinking about what can I pull from other industries outside of pharmacy that would be helpful. So here's a problem that I have, right? Technician training. There's a whole lot of pathways I could go down with technician training and solving different areas of need or creating different education options. And even just thinking about, okay, but if I layer on all of these things, am I going to cause burnout with technicians? Because there's also this need for more people. I actually started researching then in my MBA program, looking at the Chick-fil-A training model and Starbucks, and how do you get all of these people across the nation to be really happy at 6 a.m. serving me coffee with a really complicated order. So yeah, definitely trying to tie all of that together. And I probably also after that did start looking at other programs like, okay, if I didn't just get my MBA, what else would be helpful now to like spearhead some of these ideas? But now I have a list of places that instead of getting a degree in that program, I want to be asked to speak there. And
That's your goal.
Yes. The one in particular is the master's in healthcare science at Dartmouth. I want to be asked to speak at that versus get the master's.
Not both. You want to speak there.
Yes.
Versus go there.
So the premise behind that master's is that you have to be in a position to make systems-wide change. And so the typical age is like 47 for the average person in that program. Basically, they have this very strong continuation for alumni because as soon as you graduate, what you learned is changing on healthcare delivery science. So I want to be asked to speak at one of their alumni events because that's my goal, to make systems-wide change.
Goals are beautiful, but they're difficult because you're at the whim of somebody asking you to fulfill that goal. Someone else is included in that goal. You can do a lot of it. You can show up and you can market yourself and you can be known as this or that. But it might be on the day of asking or something like that. Somebody has, decided to go to lunch and the other person was a decision maker that day or something. In my life, I have one thing on purpose, and that is I love to play the piano. I love to practice my sight reading. And I don't give a rat's ass if anybody hears me. In fact, I don't want anybody to hear me. I can, play for a good long time, and it's fulfilling. I'm not doing it for anybody. There's nobody in my way. I can't blame anybody. It's all me. There's not a lot of stuff like that in the professional world because you're kind of at the whim of people sometimes. So it's good to have the goals. And I've got them too with the podcast and business and the pharmacy. I've got goals too, but there's someone else that has to make those goals come true too. And that kind of sucks sometimes because it's not your own, it's depending on someone else too. And it's a whole thing about you create your own luck and all that kind of stuff. But I know you're going to hit that goal, Annie. I just want to say the lady who's going to be asking you might be in a bad mood that day or something.
And that's a really good point. I would probably use the analogy that my husband has his dream car that he can attain buying in his lifetime. And that's a Porsche 911. And then the Lamborghini Aventador is his dream car that he doesn't anticipate ever meeting that dream unless, different things were put in place. This is probably more of a fun, hang the hat on the gold star because it's probably not even the North Star, especially just in thinking, okay, my ultimate motivation, while I love patient interaction, is to change the system and make it all better for everybody using pharmacists. And so I think with that, saying that I want to be heard and asked to speak, not even promoting myself to this area. This is not some group that puts out any requests for speakers either. They would come to me. That would mean that I would have surpassed or built a program or a goal or something that we did that was bigger than pharmacy and big enough for healthcare to pull and say, okay, here's something we need to learn from. I probably don't do this on my own either. So let me caveat that by saying this is not Annie does all of the steps by herself. So I bet there's also some luck involved or just some chance meeting the right person at the right time in the right room. Probably a lot of that, not just one.
I would imagine part of the goal of hitting a goal is to go way past what is needed for that to happen so they can hardly not invite you. It's the same thing as the basketball player who turns up the stereo real loud, louder than the crowd's going to be in order to surpass different conflicts so that the actual goal is not going to be that big. And so just by talking to you, I know that you're going to go way past it. So they have no choice but to ask you to go to it.
That's right. Kind of like, do they say that the the overall experts spend at least 10,000 hours on their craft. So like piano, like you would have had to spend 10,000 hours. And I've not broken that down.
10,000 hours, I figured it out. It's like an hour a day for 30 years.
I did not read the book that came from a business mind.
Yeah, that was a book.
But
I forget the guy's name.
Yes, I do too. So 1 hour a day for 30 years doesn't sound like crazy. But I feel like, to your point, it's practice that you are basically putting all of your effort into making it better. And I think that's also key actually in business or anything else. Like my goal in developing the next idea or the next program or even a section of the program or the training or whatever it is basically what did I do in the past and what can I do to make those better? So if I did something that worked, what can I tweak just a little bit to make it better? Versus looking at a program that was really successful and saying, check, we're done. We have a vaccine gap closure program that hit 75,000 education interventions with pharmacists and CHWs. So if I were to say that was actually surpassing all my expectations and check, we're done, versus, okay, next time I'm going to tweak this and this and this to make it better. And even not so much those metric goals, like, okay, next time I want to hit 76,000. But to say next time I want at the end, when I ask for feedback, I want to hear different questions, not the same.
Goal setting, that's all we can do really compared to ourselves one day to the next. All right, Andy, now let's back up a little bit. This show, it's the business of pharmacy, so we don't talk about silly things like how drugs work and how we care for patients and things like that. That's all the boring stuff. We don't talk about that. But let's back up a little bit. So from what I gather, your goal has been to use your pharmacy degree to make a lot of change, health change in the world, but reach further than pharmacy has into the more mainstream. Is that about right?
Yes, probably not, probably almost by chance a little bit too, but yes. Some of it not realizing, that I could use this pharmacy degree and in a space where I might be the only pharmacy voice, be able to say, no, that's not going to work. We should do this and it'll be 10 times better.
So you were in community pharmacy for about 5 years.
Mm-hmm.
And were you in a retail setting, a community setting?
Yes. So I worked at a grocery store chain in St. Louis, so urban area, and then moved and worked for an independent pharmacy in rural Missouri.
Annie, that time, was that something you said, I want to expand the great things I've seen here? Or is it, I'm not seeing anything happening here and I've got to make change?
Ooh, that's a good question. Yes, probably a mixture of both, not necessarily saying that there wasn't anything happening in the pharmacies, but more I could see what barriers were there and what walls needed to come down, either in the chain setting or in the independent. It was almost more what barriers or walls right outside of our own that needed to come down to be able to do more. And then also like kind of comparing pharmacy to other healthcare spaces. If this is what we want to do, why aren't we doing it at all like other healthcare providers? So how we utilize our pharmacy technicians and where is the value of pharmacy even? So I remember like in school and in those first 5 years saying, if you had asked me what is the value that pharmacists bring to the healthcare system and why should we pay pharmacists to do anything more than check medications? I would have said, oh, well, yeah, we're the medication experts. To anyone outside of pharmacy, that doesn't bring value to the healthcare team. I mean, yes, you can like break it down into bits and pieces, but the big value that I saw that we could be providing this angle in was in the follow-up and monitoring. So I would see patients once a week or every month, or I'd see them come through the drive-through and I'd get to meet their pets, and that we have delivery drivers that go to their homes. On Christmas Eve, I remember our delivery driver was gone, and so I delivered a medication to a patient, and getting to see where they live, how they live, the fact that the insulin is on the fridge, not in the fridge. That is not happening elsewhere. So when you go to your primary care's office, if they called me 3 months later, I wouldn't answer the phone. But I can tell you that the patients on MedSync, if I didn't call them or they missed my call, it was a not happy patient saying, hey, where was my call? I didn't get a call this month. So they're answering the phone. We have touch points every month and reasons that the patients are coming in. So I may miss a doctor's appointment for other life priorities. I have 2 kids, I have 2 dogs, things come up, but I would make it a point to go to the pharmacy every month and get our medication. So there's also this tie to a product. While we don't necessarily always like that, that's a reason that the patient's coming in regardless of whether they want healthcare advice or education, and an area to target that advice and education.
All right, Annie, now I'm going to play devil's advocate to this just to get down to where we need to get down to. From a business standpoint, I like many touch points, but what precludes that is the payment. So where does that come together? It's kind of the chicken and the egg, I know, forever. But to add value, arguably, one of the ways in America we define value is it going to be paid for? It's not just do people like it. Do they like it? And are they going to pay for it? So let's talk about that.
Yes. Oh, I love this question. Okay, so this also ties in with all of our grant work to be able to build a sustainable and scalable path as well. So I'm going to focus a little bit on community pharmacy here. I think if you're trying to provide a billable or payable service in a community pharmacy, there's a couple lines that you can't cross right away because you would need funding to invest. So you really shouldn't have to buy a whole lot of different software that everybody has to have special logins for and look at separately from your current software. You may need to do that down the line, but initially, no. You shouldn't have to have separate space. Again, could be an expansion down the line, scaling up, but initially, no. And then you also shouldn't need to hire additional staff. Now, hire doesn't mean train or educate current staff. That just means hire somebody else. Also, right now, I think pharmacists are not utilizing their support staff to the fullest. So we're super type A personalities. I am the same. So when I worked at the pharmacy and you're trying to implement something new, you are going to figure it out yourself until it's perfect, and then you will train somebody else. So in other words, you never train somebody else unless they insert themselves, right? And so that was trying to figure out how do we reach pharmacy technicians and delivery drivers and everybody else involved in the pharmacy and empower them in the same way we're empowering the pharmacist to provide additional services. Because also the ROI will never be there if it's the pharmacist checking somebody in, doing the initial data collection, gathering any like blood pressure, et cetera. And then also calling and following up and billing. Because in other healthcare spaces, they don't do that. That is not your MD coming in and connecting with you for the hour or even reminding you to come in. So that was where tying in this role of a community health worker, pharmacy technician was brilliant. This was not my idea. I'm just kind of the dot connector that connected the people who thought of it, the people who could create it, and the people who could scale and sustain, and basically bringing all of the smarter minds together. And the funding, I did bring the funding source together.
Say that again. That position is a community health technician.
So training a pharmacy technician to become a community health worker. I think of if your pharmacist is your clinical and primary care extension out in the community setting, then your technician who does not necessarily have extensive clinical or strong education background, but does have a strong sense of community, can be that social work, environmental, and basically connecting all of the social resources together to address health disparities and access to anything even in addition to healthcare. So if it's a patient that just needs help with transportation, right? Or needs help with paying for something else, electricity, whatever it is, they pull all of those resources together. And so if you think of your pharmacist as your healthcare hub, because we're getting prescriptions and we're connecting with all of the providers, not just primary care, not just the ER. And then you have your community health worker trained pharmacy technician who can also be that social extension as well. And because of the number of touch points in follow-up and monitoring, the two married together is brilliant. Also, it's kind of a forced team environment now, because now you're not saying you have a pharmacist and you have a technician and the education or clinical gap is so wide, because now you really have different expertise. And technicians are already trained extensively because of Board of Pharmacy rules to refer to that pharmacist already for clinical things. So you're not even having to tell them where that line is.
All right. So this is the team that is going to get more touch points because people like them. But now where does the payment come in?
Yes, great question. So basically now your payment is in the health equity space, as well as those per member per month value-based care arrangements. And now you're not trying to do it with one single pharmacist at a single location, because you can train pharmacy technicians to become community health workers and have an entire team dedicated to this. So when Medicaid MCOs don't get patients to answer the phone and can't keep track of patients and their care, guess who can? And guess who they will pay to do that? There's also specific CPT codes and billing codes specifically for community health workers, while there aren't necessarily yet specifically for pharmacists. I think, too, that the two together actually empowers or elevates the need to pay pharmacists as well, because community health workers not tied to a healthcare setting are not a sustainable role in other spaces. We have that tie into healthcare. So not only are you bringing all of these social resources and referrals, now you have a tech who's always 6 feet away from a pharmacist who can then tie into all of the healthcare space as well. So it's really right now the only bridge between social and healthcare outside of a social worker in a healthcare space that somebody may not go to every month like they do a pharmacy.
That technician, is that a new position and is it licensed? Does the state get their nose in it?
Yeah. So in Missouri, for example, we had to have our curriculum specifically for pharmacy technicians approved by the state and the Department of Health. And then we did have to work with our Board of Pharmacy to say what can a CHW do that's maybe different or in addition to what a pharmacy technician can do. Because if you say a pharmacy tech is not allowed to refer, that's fine in a clinical sense, but not in a social sense. They do need to be able to refer to some of these other programs. And so just working closely with our Board of Pharmacy, who's been excellent as well. We also realized that that was not specific to Missouri. So when we started developing this curriculum about 3 years ago with a pharmacy that had kind of started and spearheaded this pilot, we said, okay, we can either own this and accredit it in all 50 states, or we can work with people whose that's their expertise and their job. So thank you to CE Impact, who took this on and is accrediting it in all of the other states and territories. And then I will say too, that was an interesting discussion, like separately with what our Board of Pharmacy wanted to do versus our Department of Health not necessarily wanting to expand pharmacy technicians becoming CHWs. Did they want to just hire CHWs? So we did look at that, building that sustainable model with being able to bill and being able to provide additional services. We now actually in Missouri have network adequacy. So our entire network of pharmacies that has community health workers can meet the needs of a large percentage of the population if we were to contract with a specific payer.
All right, Annie, give me a scenario of what we're talking here. So Bob or Sally owns the independent pharmacy and they typically show up, maybe themselves are working a shift in the morning and they've got a few technicians and a delivery person, whatever. That might be a basic pharmacy. How does that look different a few years from now once this program is, maybe now, but even in a few years from now, once it's really rolling? What is that going to look like from what I described it to what is envisioned?
Okay, so you have the same number of staff in the same building.
That's right, you said
and you
that.
So you have a program now that your technicians and your delivery driver have a community health worker training.
Through CE or something, they've gotten trained.
So it depends on the state. They could go multiple places. Pharmacy specific, I know the only one in Missouri is through CE Impact, but they could go to colleges. So there's others, and each state may be a little different.
And how long, Annie, does that take for someone as you're seeing it now? How many hours sitting in front of a computer basically is that going to take somebody?
So it's about 100 to 160 hours. So it's not it's not like a weekend or a day to become immunization trained. It's 16 weeks, but actually, or 12 to 16, depending on the state. But actually the golden egg, or like the thing that is the most valuable part of the course, is the service learning hours. They spend 60 hours or 30 different meetings, which could be virtual or could be phone or in person, meeting with specific resource leaders in their community. So maybe it's the health department, maybe it's Meals on Wheels, maybe it is funding like the caring communities in the county who help with paying for medications. And so it's meeting all of the different contacts and leads and how is a patient eligible, who is eligible, how can I make sure that anyone who needs this resource knows about it, because now we know about it because the CHWs. So they build this binder of community resources.
That's part of the training, the focus. Yeah. That's beautiful what you said about you don't need to invest in more computers, more space, more people, and so on.
Yes.
So, Annie, I want to bring up stuff as they come up because my wife says I'm skeptical, and she's probably right. This 60 hours that these 3 people have to get, the technicians, is that going to be on while they're working? Because you said we don't need more people, but if you take 180 hours over 3 people, that's time away from the customers. When is that part done?
Yeah, so it depends on the business and what makes sense for you. So I know for pharmacies in Missouri, there are some that did pay their technicians during that time, for example. And so the course is usually, like the live portion is usually on Tuesday evenings to try to accommodate community pharmacy hours at least, which our other courses offered by our state community colleges were always during the day. So we could rarely get technicians away from 12 to 2 to be able to attend those live. We actually are now able to accredit or approve an on-demand option for Missouri. Not all states allow that, but we've kind of proven our sustainability case to the state. So they're allowing us to do that. And then we have a conglomerate of CHW technicians now to share best practices and questions. I will say too, back to your, like, what does this look like in 3 or 5 years when it's kind of fully cooked? I would ask that owner or pharmacist who are overseeing any of the clinical services, or really honestly, any of the business line items, how many of your technicians or delivery drivers, unless they are co-owners, are asking you, how do I bill? What's next for any line item of the business? So if you have any technician coming to you and saying, okay, I love MedSync, how do I bill for this? Or I love dispensing a specific line of medications. How do I bill for this? Because I can, at least in my experience, I never had one. I never had a technician or delivery driver empowered to ask me or the owner about a service, even if they enjoyed or were like, that was their purpose in the pharmacy. So when we ended our vaccine gap closure program that required CHW technicians, and we ended it early because of the incredible success, and we're able to just move into the next phase. So our very first post, we used Basecamp to connect with all of our pharmacy teams because it wasn't just the owners. We had 500 plus providers in technicians, CHWs. So when I posted, this is shutting down at the end of the day, the very first questions were, what's next and how do I bill? And it came from pharmacy technicians, CHWs. Owners got on later to follow up. But I thought that was interesting.
Danny, I don't want to get away from this, though, because I trust you when you say no new people and no new space and so on. Okay. But you've got 3 technicians and so-and-so only wants to work 20 hours a week and someone's at 40 and someone wants to work, 30 hours a week. Now, over 16 weeks, and it's an average of 100 to 160 hours, let's say that 8 hours a week. Where do these people come up with the extra 8 hours? Is it biting the bullet? because you can't take them away from the pharmacy for 24 hours. And maybe if they wanted to go to that kind of training, maybe they would have. Maybe they would already be a dental assistant or someone that required this kind of schooling. So where does that time come from?
Yeah, so that's another great question. I would probably call that time and money. If you can hire even a part-time person, it's back to the money. So in Missouri, that's where I looked at our grantors and said, pharmacy could be huge in this space. Like, we're already embedded in the community. Our patients answer the phone for other reasons. Like, we're not having to bind them to be able to connect and share what's needed, what screening, et cetera. And we can connect all of the dots for them. So not only are there scholarships available in a multitude of places for the course itself, but we have worked with our grant partners as well to start tying in. If this is a new program, especially in public health or population health, then we need to be paying for the training time, because that's just as valuable, if not more valuable, than the end result or the implementation. So even a CHW who's already fully trained and certified as a community health worker technician, if I'm wanting them to do a specific service in substance use disorder that requires another 6 to 8 hours of training, and I want them to actually do something with that training, then that means that that time is valuable to me as the program manager, but I should be including funding for that time if it's valuable. So that's where, too, I think, as public health or as grant writers or as grant managers, we need to be implementing that into the program, or for payers as well, to say, okay, if this is a part of a pilot for a payer or an innovation center, that you need to be layering in the training time and payment for it, either a stipend or whatever it is, because that's just as valuable as the implementation and the end result.
Okay, Annie, so thank you for that. Now, let's back up again. All right, so now this owner with these, let's say, 3 technicians. All right, so now they're trained. 16, 20 weeks has gone by, and these 3 have the CHW, and there's maybe a delivery driver and maybe some other person in the store. You got this set up. So the pharmacist and 3 CHWs and a couple others. Now what?
So I would probably back up a little bit to say, if you have one pharmacy who's the only one anywhere doing this, then you probably have a little bit more of an uphill battle, because you're likely not going to carry the same weight as a state of pharmacies or a network of pharmacies with CHW technicians.
So let's say that we're in a place...
Missouri.
Let's say that we're in Missouri. All right, now your pharmacy has committed to this and you've done this. Now you're at week 20. Now what?
Okay, so now we layer in programs that tie the social determinants of health assessments and those payers that want the data around the SDOH outcomes. So to know how many of my patients are having issues because of all of these other factors. And then 2, that's where the CHW can come in. And then the pharmacy technician now who's trained as a CHW is a little bit more empowered to be a part of the clinical or education programs from that data collection, assessment, screening. So we have started layering this type of work into what I defined as the value of pharmacy in the follow-up and monitoring that happens in a process that already exists, at least in most independent pharmacies. Maybe it's not super strong, but it exists in the software and the workflow, and that's medication synchronization.
Okay.
So we have this opportunity that we can run reports for patients who are on our MedSync. We can follow up. We can assign technicians all the different spaces. And then we also have the schedule, the timing of our deliveries, et cetera. So why are we not also using that process for building all of these other valuable billing opportunities, for lack of a better term, like education and screening?
If you're in Missouri and you've got a sync program, and that's not for us, it was rocket science. I tried sync 3 times, Annie. I'm a failure. I'm a 3-time failure.
But you also don't need to have a patient who's on a chronic medication to add them to your MedSync workflow.
Let's just say you're not a failure like I am in that category. You've got the pharmacy, you've got the MedSync set up, you've got the CHWs. And so, yes, that sounds like a real natural fit that they piggyback then onto those phone calls that are already happening.
It is basically building a conversation about a specific thing. So you could build a conversation about vaccines. You'll be, saying, did you realize that, my pharmacist did an eligibility check. It looks like you're due for your shingle shot. And the patient says, no. Okay. So next month, I'm still going to ask because I'm already calling you about your medications potentially. You're used to me calling every month. So you're still going to answer and be cordial. And I say, hey, I still care about you. So I am going to bug you. Don't forget, you still need that shingle shot. We have it at the pharmacy. And basically changing that, no way, Jose, I'm never going to get a vaccine for my shingle shot, to if I have a question about my shingle shot, I know who I'm going to ask.
All right. So we're building the scenario in my head. So now they're calling already. They're talking about this. Then typically when they're talking about that, the person might just say, yeah, I'm going to get it. Or they might bring up an issue of why they're not getting it or some other concern. Mm-hmm. So far, we haven't really used the value of the CHW in this phone call because anybody could ask about the shingles shot. I'm guessing this next part of it is where some of that CHW shines in some of the responses they get from this.
Correct. I think not only that, there's actually another layer of services that could be specifically making that CHW shine. I think the CHW role empowers your technician to shine a little bit more in this space, maybe being more comfortable with having this continuous conversation, but then also in the documentation. So if you didn't document it, you didn't do it. So if you had a 5-minute conversation about the shingle shot or whatever it is, it could be a screening too. It could be that you're due for a cancer screening. And so if you had this 5-minute conversation, now as a CHW, you're a little bit more empowered or trained to also document appropriately. And then 2, you can layer in social determinants of health screening. So if a patient says something about not affording or not having time or whatever, having other issues, it's basically this ding, 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 red flag. I know what to do to overcome these barriers. But then again, documenting and collecting that data is just as valuable to everybody else than just getting it done. So then on top of that, though, there's this whole untapped area of care coordination that I don't think pharmacists could tap into as easily or as well without a pharmacy tech CHW. So it's kind of funny. If you had asked me 5 years ago, I would have had a totally different answer than today. I think the turning point or the key to pharmacy transformation and pharmacists being able to focus on and bill for services is actually going to be on the shoulders of our pharmacy technicians becoming more trained, empowered, and kind of having their own expertise, not necessarily, again, clinical. And maybe it's not CHW specific, maybe it's other spaces. Maybe it's business, marketing, whatever it is, operations. But empowering our staff that are not clinical to have other knowledge and expertise. So with the care coordination piece, our CHWs can support coordinating a patient's care. So if we think about a vaccine, for example, but also in the face of a future potentially pandemic, to say what is the key to getting patients, whether it's testing or treatment or a vaccine, it's probably going to be someone in the community being a resource and a hub. And so that coordinator could easily be a pharmacy technician, especially thinking about the last pandemic. Who were the heroes without capes? The frontline people were all in those pharmacies, whether it was the pharmacist or the pharmacy technician and the delivery drivers. They're all still there when everybody else was at home. So I think that if you looked at that, whether it's an emergency response or just in general to address all of the health disparities that were always there, but are coming to light post-pandemic, and wanting to look at health equity and being able to reach everybody, especially the vulnerable and underserved areas, the key to that is going to be your CHWs partnered with a pharmacist.
Okay, Annie, so let's go back to that phone call. Anybody can ask if they have a shingle shot or not. But now the CHW puts their thinking cap on. The person gives a response. There's value in that response. What is the value in that? I'm going to go out on a limb here and say someone's going to pay me to collect that data. Some company is going to pay me. Is that what you mean by value? Or it's just like, well, we have more to work with because they said they're not getting this shot or something? Tell me about that value.
We live in America, so value is money. It's dollar signs. So the dollar sign behind a 5 to 15 minute education encounter about vaccines, especially if the patient does not receive the vaccine that day. So thinking about a MedSync call and telling you you're due. So when you come get your meds on Thursday, come get your shingles shot, is about $25, at least on the average physician fee schedule for that CPT code specifically. There are others associated with other education on chronic disease.
Without even giving the shot, just the education about it?
Actually, specifically without getting the shot. So if you did not get a vaccine today, and I offer you vaccine education, not necessarily in a pharmacy because pharmacists have provider status issues, but this was where, too, we tied it specifically to that CPT code to then take to our Medicaid, et cetera, and say why they should turn this on. Missouri's one. We have provider status in our state with our Medicaid program. So, yeah, looking at the average reimbursement rate.
The CHW does.
No, the pharmacist.
Pharmacist
in Missouri, sorry, yeah. But we were going to share both to say the pharmacist and a pharmacy tech under a pharmacist supervision should also be able to bill for that. So it's about $25 for a 5 to 15 minute encounter.
Through that kind of conversation, then, the person doesn't want the shot. They've been told they don't want it. I'm thinking the next step then is the key to getting some of the other community providers involved with similar questions, or at least information that the patient came up with just by jabbing about, stuff. So then what is that next step? Where is well, you said it, the value in America is the dollar. So where is the next step after they've documented they're not going to get a shot? Where does the next help come in, and how is that paid for?
Yes. So I would say that it's not a single 5 to 15 minute encounter. So it's $25 unlimited. So maybe they say no, or maybe they say, yeah, that's not on my priority list today. But I know for me, at least, I'm in healthcare and I left my PCP's office and immediately forgot, unless it was my priority, to remember what his recommendations were. So just even having that monthly reminder that this is something you need to do is helpful. And so again, $25 every month is pretty good, at least per patient. And then I would say, let's say that patient says yes. Okay, so actually I'm going to change this a little bit to make it more complicated. This is actually a patient that now has to change pharmacies. So they're not using your pharmacy for whatever reason. So how do we still say that the pharmacy is the one closing that gap in care? That is basically the CHW on steroids, to say this is the care coordination now. That CHW can coordinate them going to the health department, or them going to the VA or a provider's office or another pharmacy down the street, and basically following up after that to say, did they get it? They can check the immunization registry or the provider. So basically that care coordination of getting the patient from, yes, I want it, to where they need to go, even if it's not at that pharmacy, and saying the pharmacy team is the reason that that gap was closed. That gap in care was closed, not here, but because of us. So even to say, okay, I'm going to help you make an appointment at the health department. Because we all know trying to make appointments somewhere where you're not used to it and then getting there and checking in is kind of overwhelming. I just tried to make an appointment for physical therapy. It's a whole ordeal. Now I'm calling my insurance and trying to figure things out. So in comes the CHW. I wish I had my own personal CHW at times. So basically, I am now the CHW calling the health department, getting you an appointment, making sure that the transportation you needed shows up and gets you there, and then following up if it didn't to get basically also close that gap too. And so part of that, even if it's not a vaccine, let's say it's something that can't happen at the pharmacy, like a blood test or a urine test or whatever it is, and we are closing that gap using a CHW still, even if it's not even able to happen at the pharmacy, because we have, again, the touch points and the patient answering the phone. We have the relationship. So then eventually, too, that patient, when they have a question about it, even if they've been in O for 12 or 14 months, now, oh, my friend just died of shingles, I'm going to give you a call. Maybe not shingles. That was a bad example. But I'm going to give you a call, and now I have questions, and you're the only person who's like routinely talked to me about it. and you're most accessible. So I don't have to make an appointment to talk to you.
You get paid for that. That's what I'm looking for. I'm looking for those dollar signs, Andy.
Sorry, yes.
I'm guessing you get paid for that, just like you got paid for a unsuccessful jab at that point.
Yes.
But you get paid for that stuff too.
Yes. And it depends on where and who you're partnering with on how you get paid. So it could be a per member per month type of value-based arrangement, or there are also CPT codes around care coordination. And I want to say those range from like $60 to $80, depending on what's done and then who's involved. The payer ultimately gets to kind of say what that looks like in the contracting. But yeah, there is money there without GIR fees ever hopefully associated with them that involve using your team in a different expertise that is not solely the clinical person.
I'm preaching to the choir here to pharmacists, but pharmacists do all this stuff for free. And how they get paid for it is the person then decides to get their medicine filled at their pharmacy, and then they lose $200 from that prescription. That's what pharmacists have been up against. So now this flips everything. So now they're getting paid for services. They're not losing any money on the prescription. Hopefully they're going to gain on it sometime. Who's paying for this stuff? My guess is it's grants and maybe some government stuff. And then hopefully corporations are smart enough to say, hey, this doesn't have to be 80-year-olds we're doing this with. How about we pay pharmacists for all of our employees, because the CHWs are keeping our staff healthy. Mm-hmm. They're just like a company might have daycare for children. The CHWs are not helping that way. They're helping though with coordination and things like that. Back to who's paying for it, Annie?
Yes. So, okay, who's paying for it initially, I would say are grant opportunities or partnerships. So when I say initially, I'm talking about the scholarships and the training for that pharmacy team to basically take that step. And grants could pay for a new service or pilot to basically develop the steps needed. A grant is the infrastructure that is needed to keep it efficient and effective and share all of the best practices. But a grant's not the long-term solution. It's the starting place. So then you now have all of this data from the grant opportunity. So we have several in Missouri now that have focused on vaccine gap, but that we can tailor to diabetes, hypertension, CKD, also even in specific spaces, depending on that partnership. So maybe it's vaccine gap in nursing homes specifically, looking at not just the residents, but the staff and family who come to visit as well. So we used this model now, this framework, and said, copy, paste. Copy vaccine hesitancy education into diabetes gap closure, into any gap closure, into cancer gap closure, screenings. And so now you have a much wider range of potential payers. So it could be your employer groups, it could be Medicaid, it could be commercial plans. Basically, it's where is their gap?
Here's the question. Is there right now, not counting the administration, which some of these grants cover, getting this stuff going, but is there and who is paying right now for the CHW to talk about the vaccine or to get them to a doctor appointment, something or other? Who's paying for that? Is there anybody paying for that right now?
Yes. In Missouri, we have some regional payers specifically, and then we have discussions in the works too for a statewide payer, but I don't feel like I should get into the details yet. But ask me again in 6 months and my answer will be, yes, we have 20 people.
But there's a group now, and we haven't discussed their funding, but there's a group now that is paying for some of those members, however they define it, to close some of these gaps. Not the administration of it, but actually these phone calls and the doctor visit and so on.
Yes, I tried to exclude, we have a lot of grant opportunities and partners, but I'm trying to kind of keep that separate. So outside of even grant partnerships, saying we want to focus on a specific subset of the population and close gaps, because that's a huge area, especially in other states that don't necessarily have pharmacy involved in public health grants yet. They should. So we do have opportunities and contracts either currently or in the works. Mostly right now, they are pilots. So they're smaller, but they've started small in the last 6 months, I want to say, and have started expanding already, which to me at least is good because I'm impatient.
You might show success with these kind of things, but it's hard to prove it. You're not sewing someone's leg back on and that kind of stuff. So I know a lot of it's the documentation and proof, and then to tell someone, it's like someone being the conglomerate of corporations or the government, it's like, look, seriously, these people would have died if we didn't do this. It's not just like maybe. So it seems the big thing then is proving what you did.
Yes. So I would say two things to that. The first, but I'm going to talk about like the data to show the vaccine gap closure rates. But first, I will also say the turning point to those insurers saying, yes, we should do this is going to be when one large one says, let's use pharmacy tech CHWs and pharmacist teams, because they're all of a sudden going to have a totally different outcome than the rest, especially because you can't do this in a call center. You can't just set people down and make these phone calls because nobody answers the phone. I don't answer the phone. Like, I know when it's my pharmacy calling to talk to me about MedSync stuff, and that's it. I actually have them saved. But other than that, you better leave a voicemail or I'm not calling you back. So we're in that era. So you can't use a call center. So that's the other, is this only exists in the community pharmacy setting. So then backtracking those. So then to say, okay, we know that vaccines not only have kind of this like political side too, to like hesitancy, but I would say that we are looking at January to May of our data and saying this was not during a peak campaign of get your flu shot, get your COVID shot. So from January to May, we had about a 10% gap closure rate with just doing the 5 to 15 minute education calls. And we had about 30,000 in that period. So that's pretty good rate of people who just got talking in a 5 to 15 minute monthly conversation and went and got a gap closed. Not flu, not COVID. Those weren't available. So the focus was primarily Tdap, RSV a little bit. There was pneumonia and then shingles. And we had pharmacies that saw a 400% increase in the number of shingle shots that they gave from the prior year in that month. Just because patients didn't realize, like they know that flu and COVID's available at the pharmacy. I didn't realize I was eligible and I didn't realize you guys had this. And so that was also part of it, to say how many people were talking to you and then how many got the vaccine. So we collected that data in those follow-up calls. Now we're looking at 75,000 education interventions, and we're still processing some of that data. But to say we anticipate that that gap closure rate is significantly higher because now we're entered flu and COVID as well. And then we also added some of that care coordination for the CHWs at the end of July. And so when we look at these outcomes to say, okay, we have a reference that says it's about a little over $4,000 that saved annual healthcare spend if a patient gets a vaccine, if an adult gets a vaccine, which we only did adults. There's a whole opportunity there for kids too, but I'm not going to get into that. And so when we looked at the number of vaccines provided and gaps closed in September alone, it was over $40 million saved to the healthcare system, at least in Missouri. So that's a pretty good rate. And then again, that's like initial, taking the totals and crunching them versus diving into all of the other details, because we collected an extensive amount of demographic data, social determinants of health assessment, and then like all the chronic conditions as well. So I think even to like the patient's zip code of residence versus where the vaccine was gotten, because that's interesting as well. So hopefully we'll have data to support not only that the gaps were closed because of these pharmacies, even for, this whole entire patient population, but all of these subsets of reasons where and why you could pay a pharmacy team to do this and where they could close gaps.
I think the key to a lot of these numbers, like when you show people numbers, is, all right, if you don't pay us, screw it. We're not going to do it anymore. See, I think what pharmacy has done is we said, pay us for this. Pay us to teach someone an inhaler or whatever. And then they don't pay, and the person's coming in there and they're going to die because they're having an asthma attack, and they pick up an inhaler. Guess what? The pharmacist is going to tell them how to do that. That's an example of, it's like, paid or not, the pharmacist is going to do it. And those are hard numbers then to parse, because if I'm an insurance person, it's like, I'm not going to pay. I'm not going to do it anyways. Should I pay them? But if you get something like this where it's like, look, we helped Mrs. Smith. She didn't want to, but we helped her get her colonoscopy. And because she came in the pharmacy, no one was going to call her. She wasn't going to pick up the phone from some call center, from across the world or the country. She came in the store. We talked to her. Then she called us a week later. We set this colonoscopy up for her, and it found cancer, and it saved her life. But guess what, insurers? We ain't doing that if you don't pay us. That took some effort, and this just doesn't happen by Mike being up there and talking about, the weather. I sure as hell ain't going to talk to Mrs. Smith about her colonoscopy or my text. So it's like, screw it. We ain't going to do it. You're not going to see the value. She's going to die from it. Now these numbers make sense, because it's not something that pharmacists are just naturally going to do and everybody gets a free ride from it.
So to top that, we actually have a pilot that we did with the National Kidney Foundation looking at patients who were high risk for CKD, so patients with diabetes and hypertension, and then recommending that they go and get their kidney function testing done. We had a pharmacy specifically use a community health worker to meet them at the health department and then walk them through the process. So I'm just going to use closer numbers that are easier, but it was about this. So it's of the 200 patients that they recruited that were eligible to get this testing done, they had 50% of them complete the testing, which again, this was not at the pharmacy. They had to go to the health department and get these blood tests done. And then I think a urinalysis as well. So then come back, they also had to get that data. So they had 50% of the patients get the blood tests done and the urinalysis with the CHW support. They also said that the patients that didn't go, they had the CHW call from the health department and say, hey, it's Bobby, I'm here. So it was like this accountability buddy. The second time, most patients didn't miss. And so they found 1 in 3 of those patients had underlying kidney disease. So also take that to an insurance company and say, okay, we can address this now before they're on dialysis, or you can wait and we can address this, start education then. But that's a lot more money.
That's right. And that's a perfect example. We're on the same page. That was not going to get done without this program. It's not like they were going to come anyways and we were going to tell them how to use something because we're getting screwed by the insurances, but we love Mrs. Smith and we're going to tell her anyways about that. No, there's no way we're going to talk about kidney function or help her get there or things like that. And so that's a perfect example of this ain't happening without this program.
Yeah, this pharmacy did not have a phlebotomist on site. They had to partner with.
No, they didn't give a rat's ass, really. I mean, they care about her, but not to the point of setting all this stuff up. It's not like a Christmas Eve delivery where it's going to happen anyways. It's like, this ain't happening without this.
Right.
All right, Annie, we haven't talked a moment about involving the pharmacist somehow. My guess is that this program kind of backs you and say, we've got this in the pharmacy when someone doesn't use some injection or some steroid thing or when someone doesn't do that correctly, or they don't put this in the refrigerator, or this doesn't happen, or they don't get a follow-up. This isn't something the CHW can do. It's not in their skill set. This is the pharmacist's skill set. And guess what? They're not going to do it if they don't get paid for it, because it's something beyond what the average pharmacist thinks they're responsible for, or it takes more follow-up than the average pharmacist would do. But I'm guessing this backdoors into that to then get this value for pharmacists too.
Yes. And I think that's where now you've hit the nail on the head. This is basically our toe in the door to say, okay, we can address issues that no one else can using our pharmacy tech teams. But now we actually can say what the value is of adding that medication expert. So we have this follow-up and monitoring. Now add the medication expert. So thinking about those patients with underlying CKD, they probably have a lengthy med list that we now need to go through with their provider and say, what needs to change, what dose, et cetera. Because now maybe half of these meds are needing a half a dose or a removal because they're not being properly functioned by their kidneys. So I think having a medication optimization, but also from the context of like thinking about right now, we get paid for CMRs potentially. And once a year, we can meet with a patient and do a comprehensive medication review. But do you think that's as helpful if their medications may change throughout the year, or as when something happens to then do this medication review or optimization? I actually like the word optimization to say, we're going to look at this a little bit more holistically to say, this patient can't afford this one, take that off their list. Like basically almost a med rec on steroids. And then, so that is also an area for using the pharmacist expertise once there is this event or a diagnosis, et cetera. I will also say that like adding that 5 to 15 minute encounter on a medicine call incorporates that technician, but there's going to be clinical referrals and questions for that pharmacist. So I think thinking that $25 a month, 5 to 15 minutes is always and only the tech CHW is probably not the case. Primarily, yes, but they may pull a question for that pharmacist specifically, especially when you get outside of preventive care or primary care. Maybe you're speaking specifically for patients with diabetes, and then, they have some different individual clinical questions. I also think that's an area for documenting referrals. So you have your referrals to the social space, but then that pharmacist tying in the referrals to the rest of the healthcare system. And so having them be a part of that team as well, that opens a can of worms for the need for better health information technology and basically having these exchanges and being able to access data bidirectionally. That's actually an area too for CHWs, so not just pharmacy specific, but to have these referral loops. So to say I'm referring to this social resource, I need to make sure that that got closed and that the patient got taken care of. Or it may be kind of this continuous, the patient needs this every month, and I need to make sure that that happens. I think the same goes for the healthcare system because we're a little bit all in different spaces, different expertise in different silos. So when a patient leaves the ER or leaves the hospital and they go to their primary and they come to the pharmacy, who can help coordinate the healthcare side? That's your pharmacist.
Years ago, I wasn't in the pharmacy a whole lot. I was pissed off at the insurances and all that stuff, and I could afford. I didn't like my employees either. I didn't like a lot of my employees. They're gone now. I just didn't like being around them. I'm sure it was me, not them. I just didn't like being around them, partially because I was paying them and we were losing money and all that kind of stuff. And I was kind of in a pity party, like nobody appreciates us. The PBMs don't appreciate us. Nobody appreciates us. We're not needed. Then about 3 or 4 years ago, I go back. I go back around the time of COVID, not because of COVID, but just because of frankly, got rid of a lot of the employees. And it hit me like a ton of bricks that we're not getting paid for it, but we are needed. I haven't felt so valuable, not in the American sense, but I haven't felt so valuable in years, realizing it's like, what the hell? If I wasn't here, do you really think someone would take care of Mr. Jones the way we solve something? He'd be dead in his living room in a couple of days if we didn't do this. Here's the problem, Annie, as you see with these pharmacy deserts now, is that when I came back and this hit me like how needed we were, I gave the same care if I was getting paid or not getting paid. But guess what? When the time comes around for me to get out of there, I'm going to get out of there a hell of a lot quicker because I'm not getting paid than I would if we were getting paid and I could sustain it. And nobody knows that day when it comes. But when it comes, it could just be, I hope to do better than this, but it could just be locking the door. It's a cliff. No one knew it was coming. And now you're going to have people across the city lying dead on their shag carpet because our pharmacy wasn't there and we filled that hole. That's coming with all of these pharmacy closures, but people don't realize it because pharmacists are committed people who give and give and give without getting paid until it drops off a cliff. So people have to wake up, I think, to the value of community pharmacy, the CHWs, pharmacists, and so on. So Annie, the things that you're doing and the people you're representing today, we got to throw some names in there. I know we've got the CPESN. I know them. I know that we've got the Pharmacists Association. Who else should get a shout out now? Who's getting in the dirt with this?
So our Missouri Department of Health and Senior Services has been phenomenal with being a partner, especially in those grant opportunities. And then CE Impact took our Missouri curriculum and ran with it. So it's in 49 other states now, and I think 4 territories.
To all of them, to all the people that are doing this and helping pharmacies not fall off the cliff and people lying dead at home because pharmacists are not there. Shout out to everybody. Annie, what's the best way to get in touch with you to say, hey, I heard the show, I'm behind you, and I have this question for you?
Yes. So they can either, probably the easiest way actually is just email, because my NPA email is easy because it doesn't include my last name. So it's just Annie@morx.com. ANNIE@MORX.com. Yes.
Annie, golly, I know you're busy with all the stuff you got going on, so I appreciate you spending time with us. Our listeners appreciate it, and I look forward to following you and seeing all the great things that you're going to do.
Thank you so much. This was fun.
All right, Annie, best wishes, and we'll talk again. You've been listening to the Business of Pharmacy podcast with me, your host, Mike Kelzer. Please subscribe for all future episodes.